I'm Dr. Asim Javed and I'm an interventional cardiologist working at Rawalpindi Institute of Cardiology in Pakistan. This is a series of talks to facilitate learning of image interpretation in coronary intravascular ultrasound.
So calcification, these will be brighter than adventitia with acoustic shadowing or dropout. So this is very bright. You can see if you compare this brightness with adventitia, this is much more brighter, and then there is a dropout shadow behind it. You can't see any structure behind the calcification. So calcification, you can have spotty calcification like these spots here. These are sites of previously ruptured and healed plaques. They are more common in acute coronary syndrome than large calcific deposits. And then you can have these big calcific nodules which are mostly seen in older patients, and they are less likely to cause acute coronary syndromes. So this is a big calcific nodule you can see here. Calcium, huge dropout shadow. Calcium, huge dropout shadow. These are calcific nodules. Calcium can be superficial or it can be deep. You can see here, this is superficial because it's towards the lumen. This is deep because this is towards the adventitial side, away from the lumen. In calcification, you can only see the leading edge, but you can't see how thick this calcium is because the ultrasound rays do not cross this calcium. The superficial calcium you can see here, this is located close to the lumen, and on the other hand you can see here the deep calcium which is towards the adventitia. So this calcium actually appears as a solid block on IVUS, but it's actually collection of microfilaments that appear to coalesce. So balloon inflation will work in most cases. This acoustic shadowing can occur. This can occur even in the absence of calcification. You can have it in presence of dense fibrous tissue also. Therefore, it's correct to refer to these lesions with shadowing on IVUS as fibrocalcific lesions. And this distinction does not have any major clinical implication. So how do you quantify calcification? So you can quantify it mild if it's less than 90 degrees. That's how you measure the degrees. Or you can say that one quadrant is involved. If two quadrants are involved or it's 90 to 180 degrees, you can say it's moderate calcification. If it's more than 180 degrees or four quadrants are involved or three or four quadrants are involved, then this is severe calcification. Calcium can also produce reverberations. So reverberations are actually, they are a common finding after rotational atherectomy also. You can see here, this is rotational atherectomy, post-rotational, you can see all of these are reverberations. Why they happen? They happen because the ultrasound beam is bouncing repeatedly between the transducer and the newly polished calcium, similar to looking into one mirror with another behind you. You can even see calcification on the longitudinal section. This is the longitudinal IVUS section. You can see that behind the calcification there is a complete dropout zone. You can't see anything, but then you can go 5 millimeters, 10 millimeters proximal or distal, and you can see this intima and media, and you can do the vessel sizing by going towards proximal or distal side to see the actual size of the vessel, because here in the region of the calcification you can't really figure out where the media is to calculate the size of the vessel. Calcium then can be eccentric or eccentric. So what's a concentric calcification? When it's all 360 degrees you can see the calcium. Eccentric is when you have calcium only on one side. So in this case it's easier to dilate with a balloon or even a cutting balloon, because the cuts or the dissection that the balloon creates will be on the non-calcific side and the vessel will expand. But in this case it will be very hard to break this calcium with the balloon and put cracks in it. So this is a case which is called a napkin ring calcification, and here you need rotablation. So this is an example of a napkin ring 360 degrees severe calcification where you can see dropout zone in all 360 degrees. So that's a napkin ring calcification. So this is a 60-year-old airline pilot who during routine medical examination had a positive ETT with normal echo, and his angiogram was performed, and now he's got a proximal LED lesion which needs to be fixed, otherwise he won't be allowed to fly as per their civil aviation rules. His ostial LED seems to be aneurysmal or ectatic, so we thought rest of the LED we couldn't see much. So we did a 3.3 by 8 millimeter balloon, and that's the post ballooning result. Now I wanted to do an IVUS to see how this waist looks. Is it possible to stay with the stent in this region and not go any further ahead? So that's the IVUS run. So you can see that there is a diffuse mid LED disease, and there are two areas of severe calcification. There you go. And then we get into the aneurysmal ostial LED. So if I have still images for you here. So this part of the LED, ostial LED, is 6.5 millimeter in diameter, and this area where I was targeting to put my stent in has 4 millimeter area and diameter, and there is calcium here and there's a dropout over here, but it seems to be disease free in this region. So that's a good spot to land the stent and not get into the aneurysm actually. So the plan could be go from here and a spot stent up till this point. But what was surprising for me was that this disease that I see over here has an almost 270 degrees calcification, but this region here, which doesn't look that bad, also has a similar calcification with a very small MLA, and this is also a significant disease here, and the landing zone actually is over here. This is the normal distal reference segment to size the vessel and place the stent. So this is what our target then became, to stent from this point all the way and go up till this point here. But then we first went on with 3 millimeter NC balloon, because now we knew that the mid LED is also very tight and is very calcific. So I took a Science Expedition 3 by 28 millimeter stent, 3 because the distal reference segment was 3 millimeters. And I've used the Science because whenever I have to do a precise location, especially ostial placements where I don't want to miss the ostiums or the landing zones, I take a Science stent because I know that this stent starts exactly from the middle of the marker. Most of the stents start ahead of the marker or adjacent to the marker, but Science stent starts exactly from the middle of the marker. So I know exactly how to place the ostial stent. So this stent was placed and post-dilated, but interesting part was that after this, the IVUS catheter could not enter into the proximal part of the stent. I wanted to restudy and get a good outcome, but the IVUS would not enter the stent. So that was surprising. So I used a 3.5 millimeter non-compliant balloon, and the IVUS still was unable to cross. Then I took a 2.5 millimeter OPNC and took it up at 35 ATM pressures. So I usually do not use an oversized or 1-to-1 size OPNC balloon. I usually take a smaller size OPNC balloon and then create a crack in the calcium or the fibrosis with it, and then move on and use a bigger size NC like I did here, 3.5 millimeter NC balloon after using the OPNC. And the IVUS showed proximal malapposition. There you can see that, and it was then taken out removed with 4 millimeter NC balloon. Distally everything looked good. That's the final IVUS run, and you can see here that's the calcium where there's a dropout zone. This was the landing zone where we exactly wanted to land, and if you see, that's where my stent finished. That's the calcium, that's the dropout zone. So we were very precise with our stent placement, and the IVUS run also looks pretty good. And this is the final picture for this patient. So that's a good result. And if I had not done IVUS, I would have missed the mid-LAD lesion, and that would have been a problem later on. So IVUS predictors of stent under expansion in calcific lesions. So which calcific lesions you should be prepared that your stent may be under expanded, and you need to treat those calcific lesions before you put in a stent. You need to prepare them well, either with rotablation, cutting balloon, whatever you feel appropriate. That is a calcified lesion thickness of more than 0.5 millimeters, calcification length of more than 5 millimeter, calcium arc of more than 180 degrees, presence of superficial calcium, circumferential calcium, presence of a calcified nodule. If these features are present, calcium modification may be required for successful stent implantation, and stent expansion is the single most important factor related to long-term outcomes. However, if there was no angiographically visible calcium, so no calcium visible on angiogram, then on IVUS, even if you see a large more than 270 degrees angle of calcium, it was not associated with stent under expansion. So angiographically visible calcium is extremely important. And angiographically invisible calcium that you don't see is likely to be thin, which does not inhibit stent expansion and which can be fractured by balloon predilatation alone. So different modalities available. So you've got rotational atherectomy, with which you modify the plaque and you actually are also reducing the area of plaque. It's plaque modification that you do with rotational atherectomy. With cutting balloon, you are doing controlled cuts in the plaque. You're putting cuts in the plaque with the blades of the cutting balloon. And with lithotripsy balloon, with these lithotripsy waves, sound waves, you fracture these plaques. So deep calcification is generally more suited to balloon-based techniques such as lithotripsy or orbital atherectomy, whereas the rotational atherectomy or rotablation may be more appropriate for superficial.
See almost concentric calcification seen in this patient. This is the still image showing the same thing, and this was treated with a cutting balloon, and on the IVUS you can see this calcium fractures there. You can see the fracture lines. So that shows that cutting balloon worked. When we look at the calcium, you need to see the depth of the calcium, whether it is superficial or deep calcium. So superficial calcium is the one that is inside the intima and the media, whereas the deep calcium is the one that is inside the media and adventitia. Then you need to see the arc of the calcium. If it is 360, that is all the way around. We also call it napkin ring calcification, as seen here. If it is between 90 to 270 degrees, that is partial calcium, and then you can also have nodular calcification. And when it comes to the thickness, you can see that this is thick calcium because you can't see any reverberations of the calcium behind this. Whereas here this is thin calcium because you can see all the reverberations behind it.
Just two bonus slides for bioabsorbable stents, although they are no more here. So bioabsorbable stent, you would see instead of single stent strut, you see the sandwich type of a stent strut. So double shadows. So this is a bioabsorbable stent, and this is how it looks on the IVUS study. Again, bioabsorbable stent, you can see double lines. Instead of a single strut, you can see double lines at places of struts. So that's a bioabsorbable stent.